Hey guys, Scott and Ivo back here, the Gait Geeks, and today we're going to talk or help answer the question, is pronation always bad or is it good? Stay tuned. Hey guys, welcome back. Scott and Ivo here. Today, again, we're going to talk about that dreaded word, pronation. Oftentimes in the clinic we hear how, when an athlete or a patient comes in and they say, oh, I know my problem's that I pronate. My response is oftentimes good because you're supposed to. So Ivo, do you get that statement kind of posed to you quite a bit?
I do, and pronation, as we know, is a necessary part of the gait cycle. It is a shock absorbing mechanism along with dorsiflexion of the ankle, dropping of the contralateral hip, flexion of the knee. It's for shock absorption. If you don't have pronation, that's an issue as well. The question is, where do you pronate in the rear foot, midfoot, forefoot? How much do you pronate in each area? And then is that affecting your push off when you're going? In other words, can you get to high gear push off? Can you get the weight to the end of that first met so that you can push off through that first MTP and have high gear so it's an effective propulsive kind of gait? I think that's the biggest thing. Yeah.
I agree. It's the length of the pronation and the speed of the pronation. Oftentimes that can get you in trouble, right? So if somebody pronates excessively and they don't resupinate and they get to that bottom pronation point very quickly, they just bottom out for a long period of time and they load that same tissue for an extended period of time, which can be problematic. Versus somebody that goes through that same range of motion, but a lot slower, they're able to dissipate that force maybe a little bit better throughout that entire range, and maybe able to tolerate that a little bit more. So again, the question is, how much pronation is too much pronation, right? And that's going to vary depending on a lot of factors, the activity you're doing, body weight, foot position, foot alignment, strength of your foot musculature, the supporting structures, etc. So where do you draw the line with regards to pronation, and where do you kind of set your guide rails?
It kind of varies as far as that goes. I think backing up just for a second for people that may not totally understand about pronation, what we want to think about, the foot hits the ground, right? Your calcaneus is supposed to evert 4 to 6 degrees. The forward momentum of the tibia moves forward, and the talus should plantar flex, adduct, and evert. And that initiates internal rotation of the lower extremity, lowering of the arch, which gaps the distal tib-fib articulation and allows the ankle mortise to move through a greater range of motion. It takes the calcaneocuboid and talonavicular joint axes and takes them from a relatively perpendicular position to a relatively parallel position so that the foot can actually sink down. The navicular goes down toward the ground. This is, of course, attenuated by mostly when your foot first hits the ground, the anterior compartment. So your tib anterior, extensor dig longus, extensor hallucis longus. But as soon as that talus starts to move, and the front of the foot is flat on the ground, then the posterior compartment starts to take over and will decelerate that, largely posterior tib, but also medial gastroc, and then in some cases FHL as well as the long flexors. So when somebody is coming in, we're supposed to see that 4 to 6 degrees of calcaneal eversion if you're looking at them from the rear as they're walking down the runway or the treadmill or however you're evaluating your individuals. We're not really checking this on the table. We're looking at how they're doing it functionally. Mm-hmm. If they're in excess of that 4 to 6 degrees, so in other words, you see that calcaneus go into valgus as they go into the first part of the gait cycle, like, okay, I don't get too excited because it's supposed to do that. And then when they get to mid stance, as the opposite leg comes into swing, and they're supposed to initiate supination as they come off, do they come off with the calcaneus still in valgus and the arch still flattened? So that's more what I'm looking for. So if they don't resupinate after that foot comes through and that calcaneus doesn't go too vertical, then I consider that a problem, and as we said before, it's rear foot, midfoot, and forefoot pronation. Okay, dorsiflexion, eversion, abduction, what we're looking at. So if you have, too much rear foot pronation, or I'll give you an example. Let's back up. You have a cavus foot. A cavus foot can have no rear foot pronation, minimal midfoot pronation, and all the pronation occurs in the forefoot because it's a forefoot varus. And that forefoot has to evert, and they have to internally rotate to get that first ray down to the ground so that they can push off. So that's an issue. So it really depends upon, getting back to your original question in a very long-winded and roundabout way, where is the pronation occurring and to what degree? And then, is the patient symptomatic at that point? Sometimes if it's not broken, we don't fix it, but we maybe monitor it as far as that goes. I think the issue becomes when people are trying to stamp out all pronation, and if you do that, that can be an effective strategy in some cases, but it's going to create other issues because we need that shock absorbing mechanism. So now, yeah, your foot feels great and you don't have plantar fasciitis or posterior tibial tendonitis or something like that, but you've got knee issues, you've got hip issues because the lack of shock absorption in the lower extremity and shock attenuation just moves up the kinetic chain and creates a problem. So drawing the line, I would say largely, do they resupinate in the rear foot and in their forefoot, and when they're walking toward the camera, what does it look like on their push off? Are they toeing off in pronation, supination, or are they neutral?
So I think that was a great kind of total summary of kind of what should happen and why. But what are your thoughts, or what are your reasons, or some reasons out there as to, from an alignment standpoint, would produce some excessive pronation habits at different regions of the foot? So, for example, you already mentioned a forefoot varus, right? In the case of a cavus foot, where the foot is very rigid in the rear foot and midfoot, they got to get that foot to the ground. They internally rotate, like you said. What are some other things from like a rear foot standpoint, a general arch height standpoint, a hypermobility standpoint, and maybe in like the first ray, let's say, that can really produce maybe some prolonged pronation type of mechanics?
Well, as far as rear foot, on the table, you can look and see how much eversion they have, but the question is, what do they do with that
Mm-hmm.
while they're walking? So in my office, I would say probably the largest reason for prolonged rear foot eversion as we're going through, other than hypermobility and a poor posterior compartment control, is largely external tibial torsion. So when the foot is externally rotated, you strike on the outside of the foot and you have to come diagonally across the foot, which makes the calcaneus evert to a greater degree. So I would have to say that's probably one of the biggest indicators for rear foot things that we see. That is going to occur there. And then again, what does the integrity of their musculature look like in the midfoot? A good approximation of that is, what's their navicular differential? In other words, how much navicular drop do they have when they're weight bearing versus non-weight bearing? And you
Mm-hmm.
can measure that super duper easy. Take a piece of a book, put a piece of paper on it on the side, have them off weight bearing, mark where the navicular is, have them fully weight bear, mark where it is again, look what that distance is. Or you can get a ruler,
Mm-hmm.
anything like that. But you can eyeball it most of the time. Really subtle amounts of overpronation or underpronation, I don't see clinically make an enormous difference as
With
far as what
regards
I
to
would
the
say.
navicular drop, I'm just going to stop you there. With regards
Yeah.
to navicular, I do it all the time. I've done it a couple of different ways. I've done the sit to stand
Mhm.
method. I've also done the semi weight bearing, get the foot in neutral position to then have them fully load it and see
Mhm.
where the navicular moves to. In your eyes, I know what number is in my head that I typically think as being excessive. What do you usually use as your excessive number there for that navicular drop? Or on the other side of that, maybe the number that's too little for somebody that's got a really rigid foot that doesn't pronate a lot at all, or doesn't drop in that navicular region at all.
I don't really have a number that I'm using when I'm doing that.
Mm-hmm.
I'm mostly eyeballing it. If the movement is minimal, say 5 millimeters or less, I don't
Yeah,
think that that's enough
I
as
usually
far
think
as that.
three, like 3 to 5 or less, I think is minimal. The research that I've read shows that greater than 10 millimeters is probably too much. That's probably where it lies.
Right. And can they resupinate?
Mm-hmm.
Now, if you treat a lot of Afro-American individuals, which
Mm-hmm.
I'm sure you do, treating some of the athletes that you do,
Mm-hmm.
they have huge navicular drops. And a lot of those individuals when they're standing there, they look like they have a flat foot, but they're able to resupinate and reform their arch. So I've seen that in that racial population mostly. I haven't seen it really in a lot of others. Occasionally in Asian individuals, I've seen
Hmm.
that as well.
Hmm.
Most of the time when people flatten out, they're unable to resupinate.
Hmm.
And that's a big problem because of those joint axes remaining parallel, and that causes shear in the midfoot, and then that creates a whole bunch of other a
Right.
constellation of issues there. But also another quick thing that I do, and you probably do this as well, I look at them from the rear as they're standing, and I have
Hmm.
them just dorsiflex their toes while they're standing there on a foot tripod. So they're on their heel, the base of the first, or head of the first, head of the fifth, dorsiflex the toes. If they can resupinate at that point, in our experience, most of the time you can retrain them with their musculature and stuff.
Hmm.
It's silly to think that, oh, you're going to do a whole bunch of foot exercises and like that's going to make this problem just go away instantaneously. It doesn't work that way. It's more about motor control and having them be able to work through that range of motion and resupinate. If you keep
Hmm.
your arches supinated the whole time, then you're just going to have sore feet
Yeah,
because
I always say, how much is your body weight, right? Many of us are 100 pounds or more, and think about the muscle groups that we use to typically lift 100 pounds or more. Often like you think bench press, let's say your pecs. Many individuals have a hard time bench pressing their body weight. Let's say now we're thinking about a much smaller group of muscles to be able to lift your body weight off the ground. So yeah, I think it's a matter of tissue capacity in
Mhm.
those cases. So yeah, strengthening is very, very important, but it's not going to, in my eyes, reposition a foot. I think motor control is so much more of the factor there. I agree with you 100%. Retraining the body how to move through space properly, utilizing the strength that you have, but you're not going to take a weak muscle, get it stronger, and all of a sudden lift the foot up in the air. So that's in the case of like a pregnant woman, who is in the early to late, mid to late stages, excuse me, of of the pregnancy, and they start gaining significant amount of weight. Oftentimes, you see that arch collapse. The muscles, yeah, maybe have gotten a little weaker, but the tissue has elongated. A lot of the soft tissue has
Yeah.
elongated. Strengthening is going to help with the capacity, but it's not going to bring that foot shape to the position it was oftentimes prior to the pregnancy. So again, this is not to say that strengthening is not important, but to really think that you're going to recreate a foot that is either a hyperpronating and pes plano valgus into a more cavus type of foot, I think you're fooling yourself.
Well, right. And that's where orthotics or footwear comes in as far as guiding that motion. With your pregnant person example, somebody in particularly the third trimester that's having issues like that, yeah, they have ligamentous change. Not only that, they've got relaxin and all these other things in their body that are working against them
Right.
to create that problem. And yeah,
Right.
their feet suck and their back is sore because the arches are flattening and they're internally rotating and their dosis is increased. And they've got this 15 to 20 pound bowling ball in the front that they're doing,
Hmm.
which is making things that much worse. A lot of those things will get better, but they may not go back originally to where they are. And that's where sometimes either one, vigorous exercise, or two, more supportive footwear when you need it. Obviously, you don't want to wear it all the time because then your foot becomes weak, but do can make a huge difference as far as guiding and directing that process.
Hmm.
And then if we're on that topic and talking about that, and I think we'll probably talk about that in another podcast,
Sure.
um, but you, the device or whatever you're using to decrease the pronation needs to be appropriate. So you need to be supporting that medial longitudinal arch underneath the sustentaculum tali in that area, controlling the rear foot midfoot connection so that they're not going to overpronate or pronate through that device. And we've seen that. You see people in the motion control shoes that they crush the shoe because either one, they're too big, two, they don't have motor control, or three, the shoe's just not beefy enough to do that. Or they come in a pair of Sambas, and we treat a lot of soccer players, so
Hmm.
we see that a lot. And some of these people are big dudes and they're just like, yeah, dude, you really need to have a little bit more support here. So one, we either need to build an arch into this thing for you, or two, we're going to need to use some sort of an external device later in the day when your muscles start to fatigue to be able to have it normal. So some pronation is normal. It's a shock absorbing mechanism. It's something that we all need. We don't want to stamp it all out, but too much is when it's an issue. The question is, and I think you hit it on the head, is when you exceed tissue capacity, that's when it becomes a problem.
Correct. And just to kind of put a bow on this, what are some instances where you need to increase your shock absorption? The simplest example, or when you're walking on like an uneven, unlevel surface, for example, like a trail or what have you, having your foot's ability to manipulate itself and kind of collapse to deal with the terrain and demands. But as long as your foot is able to again, reposition and regain that structure, I think you have the best of both worlds there, and that's the key to it. Having a foot that's able to deal with the demands of the environment.
Exactly.
Awesome. All right, guys. So for Scott and Ivo, this was a little quick one here on the dreaded pronation. Is it bad? Is it good? Or does it really matter? So anyway, thanks again. Talk to you soon, and check us out on the Gait Geeks. See ya.